there are all kinds of defects, and they are all not the same. The treatment goals, however, are very, very similar. We always try to reconstruct the defect. We are there to improve the aesthetics. We have to provide anchorage, and we have to enhance bone formation. The goal of treatment is always the same, and that is for me to give the patient back what they have lost. So we have an anterior maxilla with trauma, loss of bone and loss of soft tissue, and you try to give them again the symmetry and harmony that they have lost. Similarly, on the upper right, trauma case, loss of roots, soft tissue and bone, and the goals of treatment again is symmetry and harmony. Dental defects can be divided into two. For me, they are the dental-alveolar defect, which are primarily a socket defect. The volume of bone and the amount of bone that is needed is not too much, and it is delineated by the bone and the socket. It is very different than an alveolar defect, where the socket is missing, and you have a large defect that has to be corrected by means of horizontal and vertical, or both, augmentation. The dental-alveolar defect, this is a good example, severe bone loss on the central and lateral. We went here for a delay approach. Note that the interseptal bone is there, some facial bone is missing. The area then is grafted as a staged approach. The flaps are coapted, advanced, and closed primarily. 2 implants can be placed at predetermined position, and aesthetics can be optimal. So here's the dental-alveolar defect. The compound defects or the composite defects are very different, and they can be further subdivided. In both, the socket is missing, but in this one, you still have some wall of the alveolus that will provide you blood supply. This type of a defect is completely different because there is no blood supply. The blood supply will come from osmotic circulation from the alveolus and some from the flap. How do we treat the first compound defect or composite defect? Here we have a 2.5 centimeter defect, but we have an apical extension in support of the bone. The area can be grafted. It is more predictable because we still have walls to provide the blood supply. 11 months later, and the restoration can be completed. As you can see, it is different than a defect such as this, where you have a knife edge ridge, complete loss of facial, lingual, and vertical height. It's actually subsequent to implant failure in the anterior maxilla. We use here cancellous bone, which was contained with a large titanium mesh, and reconstructed 11 millimeter vertically and horizontally 7. Now, what's in common between the composite defect and the intra-alveolar defect? We'll discuss in a second. Then we'll cover for you the allograft. Of course, there are xenografts, but they are not a subject of this lecture. And I will then continue with autogenous grafting. The common surgical design for correction of both defects are the gentle manipulation, its tension-free closure, and avoidance of dead space. The differences are substantial, and that is vascularity and topography of the defects are very different. And that will determine what to use, how to use, and will determine the vectors and distances that you have to move the flap to establish primary closure. And of course, the degree of expansion of the tissue will be different.